Depression has this ability to kind of tell you a story about all the things you're doing wrong. I would miss an early dinner time with my kids. And so at that point, like, why bother going home? Because I was already a terrible mother, therefore, so why make it home for bedtime? And it became clear that something wasn't right. And I actually screwed up the nerve to go to my PCP and said, I think I may be depressed. I think I maybe need some medication. And my recollection of this visit is my primary care doctor telling me that I was a working mom who was working too much, that somehow this was my fault. That experience really influenced my recovery and my readiness to seek care.
People who have depression may really struggle with hope. And so they may not feel all that willing to engage in treatment if they don't think things will get better. So it's really important for you to remind them that you have hope for them because you know that treatment is available and that you've seen people benefit from treatment.
A patient of mine came in recently for a visit because she had some concerns. We administered the PHQ-9 and she scored in the moderate range. We talked about her day-to-day a little bit. Is she eating okay? Is she getting any exercise, regularly? And then we talked about treatment.
It's not an either or. I don't say medications or these other non-pharmacological interventions. We need to talk to patients about both.
From an access perspective, psychotherapy may be easier said than done, whether that's a geographic issue, an insurance issue. So number one, I always acknowledge that issue. I then at least explain that there is a reason I'm recommending this.
Psychotherapy has physiological effects just like a medication would, and they tend to last longer than medication effects, understandably, because you really are learning about yourself.
When you kind of learn cognitive behavioral strategies, you're building a toolkit for how you can kind of go through life.
I might say in that safe space of a therapist's office, you get to sort of try out different ways of relating to other people, of interpreting events. So often people with depression can start really having these distorted thoughts. And psychotherapy is extremely effective at identifying that negativity, bringing it up to the light, and looking at the evidence for it. One option for many patients is online therapy or certain apps. Because there is such a mental health access problem in the country, it's no surprise that these have all kind of sprung up, but they vary widely in quality. It's important to counsel the patient, just be careful. And if you notice you're not feeling any progress, it might be time to try something different. It's always worth a conversation and worth a bit of skepticism on the part of the patient.
Understanding what is available for our patients is important, and also advocating at the local level for your practice to create some models. Like, what does it look like to have an integrated behavioral health program? And maybe we need to then start to say this is something our patients need, and how do we get it? I don't always know exactly what medicine is going to be the right medicine for an individual, but there are some medications that generally work well for a large number of our patients.
The first line of antidepressants in most cases is going to be an SSRI. They're working on serotonin. That's a neurotransmitter that is associated with calm. And so SSRIs can produce anxiety relief, improved mood, improved sense of well-being.
The SSRIs are generally fairly well tolerated. We talk about routine things like some stomach upset when you first start them, usually it gets better. Sleep can change a little bit, but it's not a huge change.
One thing that I do want to know about is any sexual side effects, because those would not be expected to go away, but there are things we could do to mitigate that. The other major thing, of course, that I want to know about is any suicidal thoughts. It's extremely uncommon, but it does happen. And of course, they need to stop the medication right away, and we need to have another appointment to kind of regroup and think about what to do. For many studies of certain SSRIs, it's really a class benefit. There's not many that there's only one of the SSRIs works and the others don't. I do tend to avoid paroxetine because it has a higher side effect burden, orthostatic hypotension, sort of more anticholinergic effects, weight gain, and so forth. Also a very short half-life. So if someone misses a dose, they start to feel it. For patients with heart disease or pregnant or nursing women, I'll often reach for sertraline just because it's been more studied. I would use that less in patients who have a lot of GI upset because there might be a little bit more incidence of that side effect.
It's not uncommon to face a patient that will not have responded to the first line of treatment. The important thing at each step is to make sure that the patient is adhering to the treatment and to have some type of measurement-based care. Sometimes just asking somebody how you're doing, until they're really meeting a certain tipping point, they're still going to say not good, even though it could be somewhat better.
The subjective experience is important, but I also want to be able to do some of those scores and be able to watch that PHQ-9 over time.
These oral antidepressants can take weeks, if not months, to really give you a full benefit. And it's important to see if there is a trend going in the right direction. We know if it's moving in the right direction, there's a good chance it's going to continue going that way. If there's no response within the first few weeks, then the chances of having a response at later points is dramatically reduced.
If it's not working, it's important to think about the different options you have. Do we augment with another medication, or do we switch to a different medication? The evidence is sort of reassuring that you can do both. Whichever path you choose, you can change to the other path after 1 to 3 trials. You start with an SSRI, and if that doesn't work, you try a different SSRI. If that doesn't work, I use an SNRI. SNRIs are working on norepinephrine or adrenaline, and that also can improve people's mood. Sometimes they notice it gives them a little bit more energy for the day. I would consider an SNRI first if there is comorbid pain, for example. I might choose something like duloxetine, venlafaxine. And sometimes patients have migraine headaches, and SNRIs are also used for those. So I might consider just trying to kill 2 birds with 1 stone. If you switch to a medication and that's not working, then why don't you try augmentation strategies?
The best evidence we have right now is it really depends on how much of a benefit the patient received from the first treatment. So if they got a good benefit but not a complete remission, you may want to augment.
You want to kind of take that partial response and just boost it up a bit. But if it's been a year or 2 that they've been on the medication, they may be undergoing a phenomenon where the antidepressant kind of loses its effectiveness, and you just need to have a holiday basically of 6 months or so from that medication, and then they could take it again in the future and find benefit from it. But in the meantime, it's probably better to switch to something else. The second line of antidepressants include atypical antidepressants, tricyclic antidepressants, and monoamine oxidase inhibitors, or MAOIs. They may not be something that you're going to prescribe, but that you know about when you're considering referral to a psychiatrist. I see a lot of patients with medical illness. They may have insomnia, they're not eating very much. For them, mirtazapine would actually be a perfect choice because it does have as a major side effect sedation when you first start it. So it's kind of nice to use it as a sleep aid in a way, and then as you uptitrate it, the sedation goes away and you get the benefits of the antidepressant effect as well. The tricyclic antidepressants, they can be very helpful with comorbid pain, but definitely when patients have maybe abdominal pain that's chronic or neuropathic pain, tricyclic antidepressants can be extremely helpful. They have downsides too. You have to monitor, their levels via labs, and they can be fatal in overdose. SSRIs and SNRIs are much safer. MAOIs are incredibly helpful, not just for atypical depression, but just treatment-resistant depression. So when someone fails 2 or 3 other medication classes, phenelzine in particular has been shown to outperform some other antidepressants. They're not used very often because there are dietary restrictions. You have to avoid tyramine-containing foods. The bigger risk, in my mind, is that you have to avoid any other serotonergic drugs. You have to have a washout period of a couple weeks, so there's no overlap.
Once we start the medication, there's usually a question at some point of, do I have to take this forever, or how long do I need to take this?
If they've only had 1 episode of depression, I think it's reasonable to trial off the antidepressant if they've been stable for at least 6 months to a year. If they have recurrent episodes of depression, I try to just explain to them, like, we can always try to go off medications, but we need to have a really good risk-benefit discussion about the benefits of being on the medication, the risks of being on the medication, or the benefits of being off the medication and the risks of being off the medication. And if someone is really like, I don't want to be on any medication anymore, I'm done, I'll say, okay, well, I will stay with you as you go off and even afterward. And let's say ahead of time, when will you know that it might be time to go back on a medication? It doesn't have to be the one we're on, but when would that be for you? And I'll often ask a spouse or a family member too, to help as well.
One of the things that I think those of us in primary care have had to figure out a little bit is following patients over time when we don't have expertise in psychiatry. This important piece of actually being there regularly for a patient can't be underestimated. Having a medical home while you're thinking about either being ready for therapy or having a therapy spot open or being ready for medications has some value.